We continue with our very exciting programming here at the M42 main stage, day 2 of Arab Health. Now, the next subject matter, I am sure, will be something that the audience really want to interact on. So please do have your questions ready. I'm going to be inviting the speakers on stage and handing over the stage to them. They don't need a moderator, they don't even need an MC, but I'll give them a very quick introduction. They are both from the Clinical Operations Health Plus Fertility, Jules MacDonald, and Dr. Waleed Syed, the Medical Director of Health Plus Fertility. Please do give them a big round of applause as they come on stage. And as I hand over, they will be talking about a new dawn in fertility, embracing innovation in IVF. Please, may I hand over to you? Thank you so much.
Thank you. We are very, very excited to be here today. This is an extremely interesting topic. I think pretty much everybody here would know somebody who's been through IVF or had some form of fertility problems or issues. So it is something that touches everybody. And we are very excited to be part of the M42 and Fertility Plus. So, firstly, for anyone that doesn't know, IVF started, it was actually 45 years ago. The UK were the first to actually have a baby that was born, but what a lot of people don't know is the Australians were the first to actually do this in 1973, but unfortunately the patient miscarried, so the Brits pulled through in 1978. As we know, infertility rates are a huge problem, and especially here in the UAE, we're finding that the numbers are actually increasing of who is needing fertility support. So innovation is a huge area that we're working on. 10 million babies have been born so far, which is extremely exciting. I do think, though, that the numbers are probably higher and should have been higher because it has taken 50 years to get this to where it is today. Now, what we need to do is work forward on how we as a company and we as a brand and we as the medical community can make this go even faster, because it is a problem that we need to address.
Good afternoon. I think we are talking about innovation of IVF. We cannot understand the situation right now before looking back. When we started in a very primitive programs. I believe, as Jules said, it's end of the 70s was the first IVF, the first successful baby born after IVF. Before, women were sterile. We call it, this is a sterility, but now it's changed. Now it's an ability to conceive, which has also an option of treatment. Then, if we talk about IVF, we have to look in two components where the development and innovation happens. One is the ovulation and ovulation induction. Two is laboratory and laboratory techniques. If I'm talking about stimulation or ovulation induction, which actually is the most important part of the IVF. In the early 60s, we started to have the gonadotropins. In the 80s, it started to have a highly purified ones. In year 2000, we have the recombinant form. So there is a continuous development of the quality of the hormones what we receive. Then, stimulation of ovulation induction was very difficult. In the start, we had always problem to adjust the right day because of the premature ovarian ovulation. The ovulation happens because there was no suppression of the premature ovulation. Patient has to be admitted in a hospital, tracking the LH, and then deciding, yes, now we are going to do the ovulation induction, and we do the egg collection. Then we have the appearance of the agonist. The gonadotropin-releasing hormone agonist was able to suppress ovulation. Then we can control the number of follicles, and we retrieve as much as possible from all sides. And stayed actually for decades, we are using the long agonist protocol. Then we had a problem with patients like polycystic ovarian patients who had severe ovarian hyperstimulations. Nowadays, we don't see it anymore. I think there is a lot of advertisement about ovarian hyperstimulation free clinics, which is right now. How did we reach this step? Patient used to have the stimulation, suppressing the pituitary, and then triggering with HCG. And then the worst thing is to make an embryo transfer. So the patient has her internal HCG and trigger really the onset, the late onset of ovarian hyperstimulation. This is a serious complication of ovulation induction for decades. Now, it's not anymore because we are using an antagonist protocol which appeared in year 2000. Then a couple of years, possibly 8 years, started the trigger of agonist and freeze all embryos because we cannot transfer in such cycles. To freeze all embryos, we have to have a proper program, a good freezing program. If we have a good freezing program, we are able to first, safety of our patients, second, increasing the pregnancy rates by transferring embryos in natural cycles, and I think this is the trend everywhere now, all over the world.
And in addition to freezing, the genetic testing of an embryo is extremely important. There's still a lot of controversy. Should we do it? Should we not do it? What is going to increase the chance of a pregnancy occurring? The issue is a lot of women miscarry. So this testing, which was innovative in the 1990s, was extremely amazing for people who have had multiple miscarriages. To be able to have this testing done and to know this embryo is normal and to put it back in is extremely exciting.
Just to mention only regarding the pre-implantation genetic diagnostic, a lot of people misunderstood that actually pre-implantation genetic diagnosis does not increase the pregnancy rate per patient. It increases the pregnancy rate per embryo transfer. There is a big difference because we abandon a lot of embryo transfers because of abnormal embryos or aneuploids. Aneuploid embryos are not able to be implanted, and if they lead to a miscarriage. The only, or maybe the 5 chromosomes which are really dangerous are the 21, the 13, 18, and any diseases by X and Y. That's why we are doing this by indication. I will not allow that all patients to do pre-implantation genetic diagnostic just to ensure for them the pregnancies, because a young patient does not require, a patient less than 35 years old, and only a simple indication for having no pregnancy, then I will do a classical IVF.
Other areas that we have found to be very innovative are being able to test an egg. This is extremely exciting, and we're the first in the UAE to be able to provide this. To be able to have eggs collected and use AI to be able to assess the eggs and advise the woman what are the chances of having a live birth with this egg. Now, this is the most important question for any woman doing egg freezing, is how many eggs do I need and what will be the outcome of this? So we now have this ability to be able to give someone an actual certificate that says this is your chance of having a baby, should you go on and do more and more. So this is exciting. Embryologists can use this tool. It will never replace embryologists, but it's something we can use as well. We also have embryoscopes, and this is a way of leaving embryos and not disrupting them and not, the environment. Every single factor affects an embryo growing. The perfume, you cannot wear perfume. Embryologists shouldn't wear makeup. There's so many factors that can affect an embryo. So we're now using modern technologies to help us make decisions.
Just to highlight the embryoscope. In the past, we had always huge incubators. When we open the door, we let a lot of air coming inside. We affect the normal progress of an embryo. Then the incubators become smaller and smaller, so we reconstruct again the atmosphere inside, so the embryo will not be affected. But still, we have to get the dish out, look under microscope if the fertilization happened, the division, and transfer to another media. Now, with this embryoscope, you inject the egg, you put inside, and you supervise from a video outside, real time, 24 hours. Embryologists can rewind and forward the videos to score the embryos, but now we don't need this. We have the artificial intelligence who is 24 hours visualizing the embryos. So he can give us an accurate score of these embryos to assist the embryologist. It's not only morphological. This is the most important. It's not only morphological. The best morphological embryo does not mean that it's the one who be implanted. The most one who can be implanted is the euploid, good configured embryo.
Another area that has been innovative is freezing. Culturally as well, you were not able to freeze embryos here a few years ago. Now, people who have excess embryos are able to freeze, and this is a huge innovation, especially for this area. Egg freezing, as we know, is a huge area, and this is something that we are really trying to work for, to encourage women to think about their fertility at a much earlier age. Universities need to speak about it, schools need to speak about it. This is something that needs to change, and women need to understand it's not. You cannot do this forever, and we need to help. And practices have changed to be able to help women have the chance of future fertility.
It's a new trend, egg freezing. I hope that all our colleagues, or our gynae doctors, or our GB doctors, they have to actually educate the women and let them make actually a normal test, which is the ovarian reserve test. This ovarian reserve can predict how many, I cannot say how many years you'll have your period, but how is the real ovarian reserve? If it's lower than normal, subnormal, then you have to visit an assisted reproductive clinic.
Let's see if we can play this. Oh, how do I go back? Video. Okay, so basically another innovative area that we are working with is ovarian tissue preservation. This is a way, especially for young cancer patients, children who are about to be given really high doses of chemotherapy, to be able to have the chance to remove part of their ovary. It's extremely exciting to be able to give someone the chance. When you're going through cancer treatment, of course, your life is the most important thing, but cancer is affecting people much younger now, and we need to think about their future. They survive cancer, they want to have a family, they should be given the chance, and it's really important, again, that the medical profession are discussing this with patients to have them know that we can do this.
I think the future will be interesting for some people who like to be always young, who wants to have an anti-aging treatment. The possibility of freezing parts, as it's been discussed here, and will be replaced later on in age. Not necessary to put it inside the ovary, could be put under the skin and will produce hormones exactly like an HRT. I think we need a little bit more data and studies to confirm this, but it looks like it's moving towards this future.
And the exciting thing of being part of M42 is that now we have the data, we have the access, we have M42. There's so many parts that can be improved in this area still. There's so much that can be done, and we're very excited to be part of this team to be able to push things forward and grow things in a different way. There are IVF doctors all around the world who don't have access to any support of asking questions, and we need to think about this with the data that we have, the information we have, and formulating algorithms and things to help with IVF. This is one area that hasn't been touched yet.
I always in my talk, I like always to give a story, short story, about how IVF turned to be doing instead of only having babies, but we are seeking to have healthy babies, not only healthy babies, that babies could help in treatment of other children, which is this example what I'm going to tell you now. I have received a patient maybe 10 years ago. She was a thalassemia carrier, both of them, and they were consanguine. It was on a consanguinity marriage. And they have a child diseased with a thalassemia. So our mission was to select an embryo which healthy or a carrier of thalassemia, then healthy from the genetic mutation in both couples as they are consanguine, and not only this, also HLA typed to be the perfect donor for the baby, for the child who is diseased with the thalassemia. It was actually a difficult mission because you have to retrieve a lot of embryos to avoid the aneuploidies and then to avoid the single gene disorder and then to have the HLA typed without thalassemia. And we finally found it after the third cycle. We transferred the embryo, patient got pregnant, she delivered a healthy child, and then The stem cell was withdrawn from the umbilical cord blood. Then the treatment was done for the diseased baby, the diseased child, with a bone marrow transfusion, bone marrow transplant. 3 years later, I saw the child, a very healthy child, cured 100% from thalassemia. So, in my opinion, this is actually our mission.
And that leads to, I guess, the ethics of all of this. Imagine 45 years ago, people saying we're going to grow a baby in a test tube. I mean, that was controversial. Now, other things need to be changed. At the moment, you can only keep an embryo for 14 days to grow it. This is an area with stem cells that we need to think about the future. As example, in terms of artificial wombs, women have problems carrying babies. If we can change the laws, if we can think differently about how we grow embryos and being able to observe things, I know it's obviously scary, but innovation, we have to be brave. This is where they were 45 years ago. They were brave to do this, and we need to be brave now, because at the end of the day, we have normal embryos. People still don't have babies. We have to think differently what is happening with the actual implantation of an embryo and what goes wrong, and that is still the area that nobody can say what is unexplained fertility, and we have to figure this out, and this is what science and innovation is going to help more babies be born around the world.
I believe there is a lot of indication for this uterus fibroids, Asherman syndrome. They have a lot of indications actually for a surrogacy. Surrogacy is not allowed in our community. Surrogacy is not allowed in the Islamic community from law and religion. So this will be the future. I believe that this will be moving towards the future alternative to the uterine transplant, because a uterine transplant is a really difficult operation with a lot of complications, and the success rate is actually not very high. So I believe this is the future.
I do too. And I think in terms of the Arab world, we need to be the leaders. I think we're still looking outside, looking at the UK. I worked in the UK 15 years. We follow the ESHRA guidelines here, which, you know, they're good, but they're also made up of IVF clinics in the UK that don't have the best success, telling us around the world how to do our treatments. So we have to be the leaders. We have the doctors here. We have the team. We should be writing the guidelines. Basically, the experts from around the world have come to the UAE. 2033, Dubai want to double their population. How are we going to do this? We have to use the teams we have and think differently and think innovation.
My last word is what is my wish for the future. Being here about now 18 years in UAE, I saw a lot of cases of premature ovarian failure, young women who the family, the parents are consanguine, so it's always coming from consanguinity. They have no option, and it's not allowed to do an egg donation. So we have only one option to try with this patient, but it's not possible to retrieve oocytes. I believe, and my wish will be, is stem cells.
Yeah.
Stem cells the scientists must work more intensive on stem cells, because I believe this will be a big revolution in the fertility treatment for polycystic ovarian patients. The other arm, we have a treatment, but for this arm, we have nothing. Even if any expert tell you this is my best protocol for poor ovarian response, it's only an accidental finding. The next cycle will be totally different. So I believe we have to really encourage the stem cells researchers is to work on this point, because if it works on women, it will work also on men. So the same principle. Thank you very much.
Thank you. Thank you.
So you ask for
Any questions, Dr. Roz?
Thanks, very nice talk. I think you both alluded to AI be able to select ovaries for IVF. Do you think this will be translating to sperm as well and increase the percentage of success in IVFs currently we have?
Actually, to select from oocytes, it's actually not difficult because we don't have that much to select from. The challenge is to select from sperms. When we have millions of sperms and we want to select the right one who carries the normal chromosomes, who looks like a sperm will fertilize an egg, we have this program already. I think this program is already a little bit older. We are using it. We tried it for a while, and we see that it gives us an idea about which sperm we should select. It marks the sperm who really moves as it's in the database. The sperm reached before to a baby, a healthy baby before, so it actually gives us a mark that this sperm could be used. I think embryologists are a little bit egoistic. They don't want somebody to tell them, choose this and choose that, but one day they will do it.
And sperm is a very big issue, as we know. A lot of people think it's the female. Obviously, it's almost equal, especially over here. There's a very big sperm issue.
Thank you, colleagues. I'm Dr. Zoe. I'm from Zimbabwe. I'm a dentist by profession,
Okay.
but obviously this topic is very dear to me because I'm a woman. My question is, what is actually the position, the global position on the potential of artificial wombs?
Well, they've done it with lambs. They've been able to get to 4 weeks with animals. At this point in time, as I said, the 14-day law of any embryologist or any scientist or a stem cell, they need the laws to be changed to allow someone to be able to keep an embryo past 14 days. At this point, they can't actually do studies. We as the medical community have to change the law. So stem cell research, they could potentially grow a baby. But at the moment, the law says you can't. So this is the problem that needs to be changed. And again, without being brave, we can't change this. So we have to be able to change things in the future.
I think you have to work first on the black box of implantation, because this is before this one. And still, we have no idea about what exactly happened by the implantation. That's why we are not guaranteeing 100% implantation rate. If we will do this, I think the science will progress further for that.
There's a lot of thoughts, it's not proven, that the body fights an embryo. It's seen as a foreign matter, and what happens when it goes inside. So there are some treatments that are controversial, like blood thinners and steroids and different things, because autoimmune issues affect this as well. So there are some treatments that are controversial that, again, the medical world aren't there to feel that it's the right thing to do. But if you're a woman, as I was, that wanted a baby, you will do anything. You will take any drug, you will do anything. And if it doesn't hurt you, then this is where the research, no research has proven it helps, but does it prove it doesn't help? And does it prove that it's actually going to hurt? We need to think differently about the other aspects of implantation.
It's also not embryo, it's also endometrium.
Yeah.
So the synchronization of endometrium to transfer an embryo on day 5, most probably also not all women having the implantation window in the same distance. Some women having a shorter implantation period, others having a longer. And this is the reason why fresh cycles having a lower implantation rate than frozen cycles. Because in the fresh cycle, it's a super physiological estrogen levels, which actually shortens this period and does not allow the implantation properly as a natural cycle. I don't know if you heard about endometrium receptivity array. ERA test. ERA testing is to actually see exactly the day 5. Is the day 5 is the right day 5 for the implantation window or not? And some women, they have a shift to day 9, and others having a shift to day 3. So there's a lot of discrepancy, but still, we need a lot of data.
Hello, thank you so much for this talk. It's very, very interesting. Being a stem cell researcher, I really appreciate the way that you are champions for it. So I have a question on regulatory though. So for example, someone gets their eggs frozen earlier on and they probably move out of the country. Are these eggs or samples, for example, in my case, which I think about a lot, are they allowed in the current regulatory system to be transferred to other countries?
In the law, it's not allowed. In the law, it's written not allowed. But under special circumstances and special approval, it's allowed to transfer it. There is not much companies who are doing this responsibility, but we have in communication with some of the companies who are really carrying all, even the approvals, they will do all approval for you to transfer either from to out or from out to here.
Thank you very much.
I think.
Thank you very much. I am Azam Kayase. I am gastroenterologist and clinical microbiomologist. And you know, as she said about stem cells, now there is a lot of studies and I start one project about what is the role of women or female vaginal microbiome signature in the success of infertility in the lady.
You know,
And can we start this study with you?
I was going to say there's not that much information, and I do think thinking outside the box, these are the things we need to be thinking of, yes. And we would love to work with you and see what we can do on this.
Thank you very much.
we are ready. We are ready to
Very
to
good.
do with any. Yes, I believe also it has, but there is a lot of changes happening in the vaginal flora in that time. There is pre-ovulatory, post-ovulatory, luteal. So there is a lot of changes. I think
Because we have patient and we have the lab. Everything is available with you. Why not to start?
I think we have to sit together, people.
Thank you. Thank you.
Do you want to say? No.
Okay.
Hi. I understand there's obviously various issues that women will have in trying to conceive, but are you seeing any advancements in kind of more natural therapies that are coming about that are helping women? For example, with DOR?
I personally think that not a lot of women understand their cycle. People actually go into IVF not even understanding when they ovulate. And this is, again, the education in schools and the universities for a woman to know their body. I filmed her at an IVF clinic as a trainee fertility nurse 15 years ago, and I had to read the menstrual cycle and understand the hormones. We have to understand our bodies to understand how to get pregnant. And I don't believe that a lot of women still understand 100% their bodies. And yes, there's natural things that can be done, and it's not always that we say IVF, like there's IUI, there's other areas of doing this, and it's not that you have to go straight for IVF.
Yeah, I think it was kind of more like alternative therapies, like red light therapy, which is kind of, you know, being studied a lot in Denmark and the US and the UK. So I just wondered if that was kind of making a thing over here or not.
I believe there is. We are using this option by cases which we have really problem in letting them conceive even through IVF, especially with the poor responder cases. We do a lot by cupping, for example, deep massages for the uterus. Chinese medicine is also play a very important role, and very important the old Emirati medicine called Khabana. Khabana is a kind of combination of massage, cupping, and it helped very well in the blood supply. And some cases developed ovulation, spontaneous ovulation. We had to retrieve this egg because it was a very precious egg, and we have some cases of success without hormones. With hormones, you don't respond. With the alternative medicine, it will do, but not in the first line. This will be the last question, huh? Last question.
Hi, thank you very much. So my name is Kiran. My background is maternal medicine. So I would be interested to know, is there any scope of practice in future for women who suffer with, for example, cardiomyopathies or pulmonary hypertension, where we would specifically tell them not to get pregnant, that you would do oocyte retrieval and freezing and then optimize their health before they embark on a pregnancy?
Yes, I believe this is one of the main indications of egg freezing. There is a lot of cases. Yani the main well-known cases are the cases with cancer, which you have to either operative, pre-operative radiotherapy, post-operative chemotherapy. All these cases are requiring really an egg freezing. Cases with endometriosis. Actually, I would recommend all cases with endometriosis before they undergo any kind of endometriosis removal. They have to visit the IVF physician. A lot of cases also with autoimmune disease. Autoimmune disease brings really a dramatic drop in the AMH levels and ovarian reserve. So such cases we don't see in our clinic. I think you see it in the other clinics, even in a dental clinic, for example. So it means that such cases has to visit earlier, as early as possible, because if you delay it, if I have a patient over 40 and she has very low ovarian reserve, what an egg will do for this patient? We have to understand, if I want to reach a pregnancy, I need at least 15 eggs. to reach at the end and one aploid embryo by patient over 40. And maybe also it will not reach a pregnancy. So the concept to have a proper number of eggs as early as possible.
Sadly, I know we could talk all day, but
Thank you
our
very
time
much.
is up. Thank you, everybody.
Thank you.
Fantastic.
Thank
Thank
you.
you so much.